Good afternoon, everyone. All right. No, that's Steve. That's me. Okay. All right. I need my trusty glasses. All right. My disclosures. So, this is the problem we're trying to manage. These are patients that have non-thrombotic iliac vein lesions. This is the classic lesion where the left common iliac vein is compressed by the overlying right common iliac artery, but we now know that you can get compression of the iliac vein here on the left and on the right as the artery crosses over it. And then when the common iliac artery bifurcates, you can also get compression of the external iliac vein up against the side wall, especially in the cranial portion. The incidence of iliac vein compression in the population is not small. There's a lot of patients who have asymptomatic disease, and this was first highlighted by Dr. Kibbe, looking at CAT scans in patients seen in the ED for some other reason, had abdominal pain or what have you, and what they found is that about a quarter of the patients had a greater than 50% diameter stenosis, a bit more common in women than in men, and seemed to be in a younger group at a mean of 40 years. This follow-on study by Dr. Lee et al. Published in 2024 in JVSVL shows again a fairly significant incidence of common iliac vein compression when looking at CAT scans performed for other non-venous reasons. So this is an anatomic variant to some extent in the sense of the distribution between the artery, the vein, and the underlying hard structures of the spine and pelvic sidewall. And you can see here that 47–48% of patients will have a moderate to severe stenosis. Now, if you apply that to the population of the United States, especially the younger population here, that would suggest that there's 123 million people who have a moderate to severe stenosis, if you use Dr. Lee's numbers, or 68 million patients who have a moderate stenosis or severe stenosis if you use Dr. Kibbe's number. Well, we know that that incidence of symptomatic disease is a lot less. So I would say to you that just because there's a lesion, it doesn't mean there's a problem. And we have to match up when to actually treat these patients. So who might have a clinically and physiologically relevant stenosis? Well, I think you have to go back to why is the patient seeing you? Is it seeing you because they have skin changes? Are they seeing you because they have venous stasis ulcers? Those certainly could be patients that have significant outflow obstruction. And it's not a small number. So these are patients who have varicose veins of various forms, with some hemosiderin, ulceration. And I would say these are maybe not the first patients you're going to be looking at. And in fact, you're probably never going to be looking at these patients. But these are the patients that I'm thinking about when I start thinking about who might I think could have a iliac vein outflow tract obstruction. Somebody here with unilateral leg swelling and pain with walking and some hemosiderin deposition down at the skin. This patient who's got inflammation and skin damage wrapping around the leg. You don't usually get skin changes wrapping around the leg from superficial venous reflux. It's usually more focal. And so when you see this kind of global injury, it's usually something up central in the pelvis, the same thing here. And so the other thing that we think is very important is that if you have somebody who has reflux disease in their deep system, they might be somebody who has an obstruction. But if you do your ultrasound and you see no reflux in the deep system, then you might be barking up the wrong tree, and that may not be the patient you want to evaluate for central vein stenosis. And then in the video study, we went ahead and looked at venography versus IVUS. And what we found is that IVUS detects a higher number of patients with a significant stenosis, and we'll use the number of 50% cross-sectional area as the number for discussion today, although that number is certainly not etched in the tablets of Moses. And then venography picks up some lesions that IVUS misses. But what we found in the video study was that there was a significant incidence of cross-sectional area reduction on IVUS in patients with CEAP 4, 5, and 6 disease. and that seems to be a matching of the lesions with the patient's underlying problem. The elephant in the room, of course, is what is the actual number where when you treat, what's the actual number of the stenosis that when you treat, the patient gets better. And so what we saw in the video study is that patients who were stented saw a significant improvement in their symptoms of the venous clinical severity score at 30 days and at 6 months compared to patients who were not stented. Now you could argue the patients who were not stented didn't have an iliac lesion and therefore they aren't a randomized comparative study, but it does show that when you find a lesion and you treat the patients, they do feel better. We did a post hoc analysis of the video database with receiver operating curves looking at diameter reduction based on venography and then diameter and area reduction based on IVUS, 2 different variables. And what we found is either a greater than 50%, 6% diameter reduction by IVUS or a greater than 54% area reduction by IVUS was clinically predictive of a decrease in the venous clinical severity score at 6 months. Venography at a 50% diameter stenosis was not predictive. And that's when stented. Some further analysis with the unit index suggests actually that a greater than 61% diameter stenosis in non-thrombotic lesions is a better predictor of improvement at 6 months on the venous clinical severity score than the 54% I mentioned earlier, which was for all comers. Now, this is all in line with what Dr. Raju and Neglin reported back in 2006 when they were stenting patients with NIVL lesions with a 50% cross-sectional area reduction, as they reported in their landmark paper. And what they found is that when they did that, they saw a significant clinical improvement in these patients with relief of pain, ulcer healing in a high proportion of patients, and half of the patients with swelling. So in conclusion, which NIVL lesions to stent? Well, I think patients who are venous claudicants, who have a high-grade iliac or common femoral vein stenosis should be treated. And usually this is going to be iliac. Patients who have clinical CEAP 4, 5, and 6 disease, who have a greater than 50 to 60% stenosis should be treated. I tend to look at the less severe the disease, the higher the severity of the stenosis has to be for me to intervene. Ulcer patients, I tend to be more aggressive than I am in patients who have lesser disease. But if you want to use the video study, a greater than 54% baseline area or 56% diameter, and in NIVL lesions, a 61% diameter stenosis. But again, these are small number studies that need to be verified in larger studies, and we're still waiting for that to happen. Thank you.